Moving forward to the next part of the pediatric stridor, let's continue where we left the last time. After history, we'll go for the examination. For the examination, the most important part is observation before examination. So we the some points of the history also include the general medical conditions. The patient might have some due neurological and cardiothoracic history that might lead to a vocal cord palsy, and the patient might have the congenital cardiac diseases, and patient might have skin lesions, and that lead to the cutaneous hemangiomas. And the acute obstruction, the patient give the history such as foreign body aspiration, concurrent. So we need to know the previous or past medical history and past surgical history of the patient. That are the important points of taking any history. Let's moving forward for the examination. The first and the most important part of examination is observation before examination. It's critical to assess the distress, stridor characteristics, and recession, which is a better indicator of severity than the loudness of the stridor. If the patient voice stridor is very loud, doesn't indicate the severity of the stridor, but the concurrent examination showing the recession, abdominal and chest wall recession, that's indicating the severity of the stridor. So next part is auscultation. Auscultation is more useful for detecting the hard sounds or wheezes than for localizing the stridor. And parental and also it is advised parents to make the video recording of episode. That can be very helpful. Now we will read the boxes 28.1, 28.2, and 28.3. The list of common congenital and acquired causes of obstruction in the pharynx, larynx, and trachea, respectively. If we let's let me zoom it out. If we talk about this, so okay. If we talk about the examples of naso and oropharyngeal causes, the congenital, the most common cause is guinal atresia, and which is most likely associated with the craniofacial abnormalities such as Rachel Collins syndrome, Clausen syndrome, hemifacial uh, anopia, and micrognathic glossoptosis. Micrognathic means short jaw, and glossoptosis means large tongue. These are the conditions which are the congenital causes of stridor. And what about acquired neonatal nasopharyngeal obstruction? We have most common cause is neonatal rhinitis. And what about the acquired? The acquired causes we have allergic rhinitis, adenitis, and adenotonsillar hypertrophy and foreign bodies. Other conditions include infectious causes and other conditions. If we see in congenital, if the patient has polyps in the nose, the patient might have the encephalocele, meningeocele, and some swelling in the midline, the dermoid, teratoma, glioma. If we talk about the obstruction at the level of upper area obstruction, the most common cause of the congenital is stridor is the laryngomalacia or vocal cord palsy. The congenital cause of vocal cord palsy is always bilateral, but if it's unilateral, it's indicating something else. Other causes are less likely. And if we talk about the acquired causes, then we have intubation trauma that might have led to the subglottis stenosis afterwards, some surgical trauma and laryngeal stenosis. And if we talk about acquired in children, then we have intubation, then we have infections such as croup, then we have recurrent respiratory papillomatosis. These are the most common causes of upper area obstruction. It can be foreign bodies and epiglottitis. Let's talk about the tracheal causes of obstruction. Then we have congenital, in which we have primary tracheomalacia due to weakness of the tracheal wall, or secondary tracheomalacia due to some compression or teratoma or thymoma that compressing the trachea for so long, leading to its compression. Then we have acquired neonates, then post-intubation instrumental tracheal stenosis. Then acquired in children, we have croup and foreign bodies. Now that we have examined, so I have mixed it up. Then examined it that I have discussed before. We would go for the look for the severity of the stridor by looking at the subcostal and intercostal, subcostal and intercostal suprasternal recession that indicates the severity, and also be associated with the seesaw respiration. And is the better indicator of the severity of the airway compromise. And there can be head bobbing are important and a concerning sign. What else we can check? We can assess metal instrument or mirror by checking the misting. And we can also have to examine the ear, nose, and throat and neck for any other signs. Now, how will you investigate it? Investigations. Then we have imaging. We have the first and the most important is the plain x-rays. Can be anterior, posterior, lateral, can be neck and chest, both AP and lateral view. Then what next? What signs can be found? We can have the characteristic steeple sign, which is the characteristic of the croup, or any bulky lesions such as subglottic cysts and papillomas. If the foreign body is suspected in the young children, diaphragmatic screening with video fluoroscopy is more sensitive techniques. Airway fluoroscopy and highly found to be highly specific in the diagnosis of both tracheo, but it helps us in the dynamic airway obstruction such as laryngotracheomalacia and fixed airway lesions, but its sensitivity is poor and it has not been proven to be useful screening tool. Airway fluoroscopy can be combined with contrast swallow. Contrast swallows are such as are of limited diagnostic value for the pediatric stridor and may be best employed following endoscopy. What else we have? We have bronchography using a non-ionic contrast medium. Why it's used? It's most likely used for the tracheal bronchial stenosis and malacia. And what else we have? We have echocardiography for the abnormal respirator as well as coincidental and symptomatic congenital heart diseases. Ultrasound of the vocal cords can be used but has not proven to be reasonably accurate. Laryngeal ultrasound may be demonstrate structural lesions such as cysts, polyps, and papillomas. However, it's not diagnostic. So what about the CT, MRI, and imaging techniques, CT and MRI? These are excellent for finding the extrinsic compressions, vascular rings, and fixed lesions after endoscopy, but poor for evaluating the dynamic collapses like malicious. Echocardy, we have known that is essential for the suspected vascular compression. So what do we do? These all have pros and cons. So what is the best investigation, which is the best in gold standard? Then we have endoscopy. Endoscopy is the gold standard. Awake flexible endoscopy, which we can say that FODL, a good screening tool in clinical, useful for the dynamic assessment such as vocal cord movement, but view can be suboptimal and it can be missed secondary pathologies. Other is the rigid laryngotracheobronchoscopy under GA, for which we need, this is a definitive diagnostic procedure. It requires full team and specialized equipment. So we need anesthesia. Typically uses spontaneous respiration to allow the assessment of the dynamic airways, and techniques include volatile agents such as total intravenous anesthesia. We have spontaneous respiration, which is very important technique, and that includes total volatile agents such as sevoflurane. Techniques involves a systemic examination using suspension laryngoscopy and rigid telescope and bronchoscopy to view all structures from the supraglottis to the main bronchus. A photo documentation is emphasized. These are all the things that we have investigations, and we have read the imaging and respiratory function tests for the flow loop volumes and polysomnography for sleep studies. Lung function tests such as flow inspiratory, and the loop will disappear in inspiratory stridor and expiratory loop will disappear in inspiratory stridor. And if there is fixed obstruction, there will be loss of both loops. Assessment of the reflex, we have radio-opaque contrast studies such as milk skin, which is a nuclear medicine, and pH study or endoscopy. Endoscopy that I have told you earlier, that awake endoscopy, which in adults we use 4 mm, but in children we use thin 2 mm scope. And what else? These, but laryngobronchoscopy is the gold standard assessment of the Stridor's child. The advent of video and high quality helps in documentation. So now we have told you that anesthesia it should be done in spontaneous respiration rather than in paralysis. And techniques as involves a total intravenous anesthesia, and it uses sevoflurane. Sevoflurane is non-irritant solvent, which is rapidly with onset of no pungency and immediate delivery. And what about the jet ventilation? This technique allows the child to be paralyzed, preventing coughing and gagging. Gas exchange is maintained by short pulse of oxygen and anesthetic gases. Subglottic jet ventilation may be provided for adults using transglottic cannula. Only impractical but also risk of barotrauma and pneumothorax and air trapping. This is the drawback of using jet ventilation. And there's also airway tube technique where you can use ETT tube or as nasopharyngeal airway prong. There is also the laryngeal mask airway, and there's a bronchoscopy technique provides a means of activity